Assalamu alaikum. It's a series of lecture regarding obstetrics. It's a sixth part in a row, likely to discuss about the preterm delivery. It's a very emergency topic. Hope you enjoy. Auzubillahi minash shaitanir rajim. Bismillahirrahmanirrahim. Preterm birth prevention. Prior preterm delivery. Yes, prior preterm delivery associated with painful contraction. If there is prior preterm delivery present or not. Prior preterm delivery associated with painful contraction present, yes. Prior preterm labor, yes. Preterm labor means a regular contraction causing cervical changes at less than 37 weeks of gestation with intact membrane. In such a case, intramuscular 17 hydroxyprogesterone should be given. If prior preterm delivery associated with painful contraction, there is no painful contraction, cervical insufficiency, prophylactic circulation should be given. Prior preterm labor, no. Second trimester transvaginal ultrasound for cervical length. Normal cervical length routine care should be done. Incidental short cervix less than 2.5 centimeter at less than 24 weeks. Vaginal progesterone should be given. So, preterm delivery, preterm birth prevention. How we can do preterm birth prevention? Prior preterm delivery, yes or no? If yes, prior preterm delivery with associated with painful contraction, yes. Prior preterm labor, in such a case, intramuscular 17 hydroxyprogesterone should be given. If no, then cervical insufficiency. At that case, prophylactic circulation should be given. In prior preterm labor, there is no prior preterm labor. Second trimester transvaginal ultrasound for cervical length. Normal cervical length, routine care, incidental short cervix less than 2.5 centimeter at less than 24 weeks. Vaginal progesterone should be given. This is all about preterm labor. Preterm delivery is common obstetric complication and leading to cause of neonatal morbidity and mortality. The greatest risk factor for preterm delivery is prior spontaneous preterm delivery, but additional risk factors include tobacco use, multiple gestation, prior cervical surgery like cervical conization for patient with no prior preterm delivery, transvaginal cervical length. Uh, no prior preterm delivery, transvaginal cervical length should be measured, and these should be done in 16 to 24 weeks of gestation. If it is less than 2.5 centimeter, then vaginal position should be given. So for patient with no prior preterm delivery, a transvaginal cervical length measurement is recommended when in 16 to 24 weeks of gestation to assess the risk of preterm delivery. To assess the risk of preterm delivery, those with incidental short cervix, cervical length less than 2.5 centimeter on ultrasound are associated with increased risk for preterm delivery. The higher risk of preterm delivery is likely due to inability of a shortened cervix to tolerate normal intermittent contraction with increasing gestational age and thereby allowing for preterm cervical dilatation and effacement. Therefore, patients with incidental short cervix are offered Therefore, for patients with incidental short cervix are offered vaginal progesterone to decrease prostaglandin production and maintain uterine relaxation throughout the pregnancy, and thereby decreasing the preterm labor. So, if there is incidental short cervix, vaginal progesterone should be given. For that reason, there is decreased prostaglandin production, which maintains the uterine relaxation throughout the pregnancy and thereby decreasing the risk of preterm labor. And in preterm labor management, maternal instability, intrauterine infection, fetal distress or demise, yes, immediate delivery should be done. So in preterm labor, maternal instability, intrauterine infection, fetal distress or demise, yes, immediate delivery should be done. Then the if no, if these three things is not present, if MIF is not present, MIF is also known as when Mullerian inhibiting factor, but in this case this is not Mullerian inhibiting factor. So maternal instability, intrauterine infection, fetal distress or demise, yes, immediate delivery should be done. If no, then less than 32 weeks 4, then less than 32 weeks is 4, 32 to 33 weeks is 3, and 32 to 30 34 to 37 weeks of pregnancy is 2. What does that mean? Less than 32 weeks. Antenatal corticosteroid, yes. Penicillin if GVS is positive, yes. Tocolytics, indomethacin, and Maxel. These four things. If it is less than very preterm, less than 32 weeks. If it is moderate preterm, 32 to 34 weeks of pregnancy, antenatal corticosteroid, penicillin if GVS. In such case, tocolytic is nifedipine. Nifedipine is a calcium channel blocker. In tocolytic should be given in 34 to 37 weeks of late preterm, antenatal corticosteroid, and penicillin if GVS or unknown. Preterm labor is regular contraction causing cervical change. Regular contraction causing cervical change at less than 37 weeks of gestation with intact membrane. In preterm labor, there is intact membrane causing cervical change below 37 weeks of gestation. So, three things in here. In preterm labor, the three criteria should be met. One is below 37 weeks, another is intact membrane, another is regular contraction causing cervical changes. So preterm labor, preterm management, this is preterm birth prevention. So I am just repeating this again because two these now we are studying very high health topics. This should be, remember, this should be taken very seriously because you have to deal lots of question with this type of thing, and this is the thing you have to uh, work on in the emergency field. In the emergency field, you have to take a rapid decision. If you don't know this type of charts, you are unable to take a rapid decision. So preterm, if a if a lady come with a prior preterm delivery, preterm birth patient, how will do preterm birth patient? First of all, I will ask her, prior to preterm delivery, yes or no? If there is prior preterm delivery, it is associated with painful contraction, yes or no? If it is associated with painful contraction prior preterm labor, then intramuscular 17 hydroxyprogesterone should be given. And I have already discussed that what is preterm labor. Preterm labor is in here. There are some criteria. It should be below 37 weeks of gestation with intact membrane, and in here there is regular contraction causing cervical change, below 37 weeks of gestation with intact membrane. This is preterm labor. So if there is prior preterm labor associated with painful contraction, yes, then you should give intramuscular 17 hydroxyprogesterone. If it is no, then cervical insufficiency should be thought, and prophylactic cervical circulation should be given. If it is no, if no prior preterm labor, then what you should do you should do second trimester transvaginal ultrasound for cervical length. Second trimester transvaginal ultrasound for cervical length. if normal cervix if normal cervical length, routine care should be done. If the incidental short cervix less than 2.5 centimeter, less than 24 weeks, vaginal progesterone should be given. Why we are giving such sort of progesterone? Why we are giving such kind of progesterone? Okay, patients with incidental short cervix are offered vaginal progesterone, which decreases prostaglandin production and maintains uterine relaxation throughout the pregnancy, and thereby decreasing the preterm labor and thereby decreasing the preterm labor. This is the thing. I have uh, I have just tried to look at the chart and see these things carefully. See these things carefully. Okay, then after this, then preterm labor. If there is preterm labor, if there is MIF present or not, that means maternal instability, intrauterine infection, fetal demise or distress. If preterm labor with these three, yes, go for delivery. No, then if it is less than 32 weeks, if it is 32 to 34 weeks, if it is more than uh, if it is 34 to 37 weeks. If it is less than 32 weeks, four things should be thought: antenatal corticosteroid, penicillin if devious or not, tocolytics, tocolytics. Mm, for tocolytics, you should give for tocolytic you should give indomethacin, and finally Maxsulf. Finally Maxsulf. If it is less than 32 weeks, if it is 32 to 34 weeks, if it is 32 to 34 weeks, then antenatal corticosteroid penicillin if GBS, or penicillin if GBS, and tocolytics nifedipine. If it is 34 to 37 weeks, antenatal corticosteroid penicillin if GBS or unknown, penicillin if GBS or unknown. I have already discussed this box. If it is less than 32 weeks, fourth thing, antenatal corticosteroid betamethasone can be chosen. Betamethasone can be chosen. Antenatal corticosteroid, penicillin if GBS, tocolytics if it is indomethacin, and Maxsulf. If it is 32 to 34 weeks, antenatal corticosteroid betamethasone, penicillin if GBS, and for tocolytic nifedipine can be chosen. And 34 to 36 or 34 to 37 weeks, betamethasone and penicillin if GBS. Why we are not giving above 34? The tocolytics, indomethacin, oligohydramnios, because it can cause oligohydramnios and closure of the ductus arteriosus, and nifedipine, maternal hypotension and tachycardia neonatal risk of preterm outweigh the neonatal risk of preterm delivery. Indomethacin can result in oligohydramnios, amniotic fluid less than 5 cm with prolonged administration. Therefore, patient typically receive indomethacin less than 48 hours. The oligohydramnios is associated with indomethacin use, typically transient and resolves without intervention once the medication is discontinued. Indomethacin given less than 48 hours. If it is given more than 48 hours, oligohydramnios can happen. Preterm labor, more than 34 weeks of gestation, who have no contraindication to the vaginal delivery and receive expectant labor management. Maxulf is used for fetal neuroprotection, cerebral palsy risk reduction, for fetus at risk for preterm below 32 weeks of gestation. It can also can be used as seizure prophylaxis in patient or in treatment for preeclampsia and eclampsia. So Maxulf is used for fetal neuroprotection, for cerebral palsy risk reduction, for cerebral palsy risk reduction. Now, preterm, pre-labor, rupture of the membrane, pre-prom, preterm, premature rupture of the membrane rupture at less than 37 weeks prior to labor onset. The cervix is closed, but rupture of the membrane happens less than 37 weeks. Is called preterm, pre-labor rupture of the membrane. It happens prior pre-prom, genital infection, and antepartum bleeding. And the diagnosis done by the VNF, vaginal pooling or fluid from cervix, nitrogen positive fluid, farning, if microscopy. So for pre-prom, what you should remember, that PGA. You should remember the PGAs. That means prior pre-prom, genital urinary infection, prior pre-prom, genital urinary infection, bacterial vaginosis, asymptomatic bacteria or bacterial vaginosis, and antepartum bleeding, PGA. Diagnosis is VNF. Diagnosis is VNF, vaginal flooding, nitrogen pulling, nitrogen positive, and farning test, farning. Less than 34 weeks, latent antibiotic and corticosteroid, less than 30 latent antibiotic, corticosteroid, less than reassuring. If it is non-reassuring, then delivery should be done. Delivery should be done. Delivery should be done. Non-reassuring, delivery should be done. If reassuring and non-reassuring, if it is more than 34 weeks, delivery should be done. This is very high yield. These things are very, very high yield. So, what should be the management? Less than 34, non-reassuring, reassuring lattice antibiotic and corticosteroid. Less than 34, non-reassuring delivery. More than 34, delivery. Preterm labor, intramittent infection, placental abruption, umbilical cord prolapse. These are the four complications may happen due to pre-prom, due to pre-prom. One of my friend name, she's not my friend actually. Okay, moving on. So for remembering pre-prom, that means preterm, pre-labor, rupture of the membrane. Preterm, pre-labor, rupture of the membrane. First thing, PGA, that means prior pre-prom, prior preterm, pre-labor, rupture of the membrane. The intrauterine infection like asymptomatic bacteria or bacterial vaginosis or antepartum bleeding. If diagnosis is VNF, VNF, what does VNF means? Vaginal bleeding, nitrogen test, and Fernie on microscopy. And the treatment less than 34, non-reassuring. Let us send very corticosteroid less than 34, reassuring, non less than 34, reassuring. Let us send very corticosteroid less than 34, non-reassuring. Delivery more than 34 weeks delivery, and the complication is preterm labor, placental abruption, and amniotic infection, umbilical cord prolapse. So umbilical cord prolapse. So management in short, that preterm, pre-labor rupture of the membrane, preterm, pre-labor rupture of the membrane, preterm, pre-labor rupture of the membrane. If it is less than 34 weeks, if it is less than 34 weeks, if it is 34 to 37 weeks, if it is preterm, pre-labor rupture of the membrane, if it is 34 to 37 weeks, delivery, GPS prophylaxis. The without corticosteroid. An uncomplicated expected management, latency antibiotic, corticosteroid, fetal surveillance, antibiotic is high yield antibiotic, ampicillin and azithromycin. If it is infection, there is MIF, maternal compromise infection, maternal fetal compromise. Delivery, intraamniotic treatment like ampicillin and gentamicin, corticosteroid. Uh, Intraamniotic treatment, ampicillin, corticosteroid, and magnesium if it is less than 32 weeks. If it is less than 32 weeks. So, preterm, pre-labor rupture of the membrane. If it is less than 34 weeks, if it is 34 to less than 37 weeks, if it is less than 34 weeks, if it is uncomplicated, or MIF, if it is uncomplicated, that means expected management. First of all, latency, antibiotic, ampicillin, gentamicin, corticosteroid, fetal surveillance. If it is maternal or fetal compromise and infection, then delivery, intraamniotic treatment like these two antibiotic, ampicillin and gentamicin, corticosteroid, and Maxulf if it is less than 32 weeks. Magnesium if 34 but less than 37 weeks, less than 37 weeks delivery, GVS prophylaxis, penicillin G and corticosteroid. Patient less than 37 weeks of gestation with vaginal pooling of nitrogen positive fluid, vaginal pooling of nitrogen positive fluid, and a closed cervix. And a closed cervix has preterm pre-labor rupture of the membrane. So less than 37 vaginal pooling nitrogen positive fluid plus closed cervix. Two things must be present: closed cervix and vaginal pooling has preterm pre-labor rupture of the membrane. Risk factor: prior condition that over resistance the membrane like polyhydramnios, condition that inflame or weaken the membrane such as antepartum bleeding, genitourinary infection, bacterial vaginosis, gonorrhea, asymptomatic bacteriuria, asymptomatic bacteriuria. There may be asymptomatic bacteriuria. Due to these risks, all patients require urine culture. Require urine culture screening at the initial prenatal visit, and high-risk patients less than 25 undergo STD screening. Those who screen positive require timely treatment and repeat culture after the treatment. Test of cure reduce the risk of persistent infection. So, due to this type of risk, all patients require urine culture uh, pre pre-prom less than 34 weeks of gestation are high risk of prematurity related fetal morbidity and mortality. Prophylactic antibiotic pre-prom is commonly due to subclinical intraamniotic infection, and antenatal corticosteroid should be given. Fetal surveillance, non-stress test, and fetal growth ultrasound should be done. Extremes of maternal age less than 17, more than 35 are associated with preterm labor and preterm pre-prom. These multiparity is associated with precipitous labor and increased risk of PPH, not preterm pre-labor rupture of the membrane. Multiparity increased risk of PPH, but not these. Patient with placenta previa can cause antepartum bleeding with increased risk of preterm pre-labor rupture of the membrane. Antepartum bleeding is one of the cause. Prior cervical surgery, uterine procedure, multiple dilation, and evacuation are associated with preterm labor. Previous spontaneous abortion is not associated with preterm pre-labor rupture of the membrane. Prior cesarean delivery increase the risk of abdominal placentation, placenta accreta. So I will discuss these topics in a separate video. Hope you enjoyed this thing.